Everyone, and thank you very much for the opportunity to be here and to speak with you, and thank you to the Italian Sports Physiotherapy Association, and congratulations to the organising committee for putting together such a great conference, and again congratulations for the achievement of the IFSPT accreditation status as well too. And some of the things I'll be talking about will relate to some of the competencies that you need to achieve to meet that qualification or that recognition as an international registered sports physical therapist. So Tony set the scene for me very well, because he's basically given you an explanation of the changes to the SCAT-5, to the Sports Concussion Assessment Test for version 5, and also some of the consensus statement that underpins that. And my job is to try to talk about some of the interventions that physiotherapists, or more accurately sports physiotherapists, might be using when they are involved in the management of concussion. And I think even that we're talking at this point in time about physiotherapists being involved in the management of concussion would be something that many of us years ago would have thought was a very unlikely concept. I mean, after all, it's a brain injury. What a physio is going to be doing in terms of managing a sports-related brain injury? And yet when you think about it, physiotherapy encompasses the practice of improving movement and improving function, and some physiotherapists who specialise in neurological rehabilitation are managing people with brain injury. And I think sometimes in sports physiotherapy and neurological physiotherapy there is an overlap, and the concept of improving motor control, strength and coordination, there is clearly an overlap, and perhaps in concussion there's a bit more of an overlap than we might have imagined, and I'll show you some of the more recent papers that probably suggest that. Can I ask, maybe hands up, of those of you who are here, any of you involved in a role where you actually do on-field coverage, where you actually are working with a team or a sport, where you actually provide services to injured athletes on the field of play? Hands up anyone who's actually involved in that sort of role. A few, not so many. Okay. If you're part of a sports team, is there a doctor present for those? Sometimes. But sometimes it might be that as a physiotherapist, if you're working in that coverage role, you might be the most qualified person who's there, and that brings with it a special level of responsibility, and we'll talk a little bit about that as well. So what I'm going to try to talk about within the time is we're going to talk about the role of the sports physiotherapist in the management of concussion. I'm going to break it largely into two parts, which is the role of the physiotherapist in the immediate management, which is generally going to be on the field of play in a sports setting, and that might be during competition, but it also might be doing training. And then we're also then going to look at what it is that we might be able to do in the clinic with the rehabilitation of people who have sports-related concussion, and then also see whether or not there may be a role for physiotherapists in the prevention of concussion, and certainly re-injury prevention. So let's see how we go. So this is Australian Catholic University Health Clinics, which is where I spend most of my time, managing a unit which provides education opportunities for physiotherapy and other allied health students. But also within the Faculty of Health Sciences at the Australian Catholic Uni, we also have a group called the Centre of Musculoskeletal Research, and that's headed by Professor Julie Hydes, and some of you will be familiar with her name as she was one of the pioneers in the use of real-time ultrasound for lumbopelvic stability, the training of multifidus and transversus abdominis initially in the management of back pain, but some of the work that Julie's been involved with in recent years has found a link between spinal stability and muscle control and sports-related injuries, not necessarily in the back. So while it's talking about musculoskeletal health, there's again a bit of a crossover with what is essentially a brain injury. And I'd like to acknowledge my friend and colleague, Felix Leong, who is a physiotherapist who is currently undertaking his doctoral studies in the area of sports-related concussion and the role of the physiotherapist. And I think you might see some publications coming through more and more with Felix's name on it. So let's start with looking at the role of the physiotherapist on the field of play, or in the sports setting, shall we say. First though, we need to go into a slight tangent, which is that we have to actually first establish the context of which we're working when we talk about the role of the physiotherapist. As I asked before, sometimes we may be providing services as part of a medical team, and it might be that there is a doctor present. And as Tony's already pointed out, the diagnosis of concussion is something that's to be made by a doctor. It's not a diagnosis a physiotherapist will make, though we may still be involved in the initial phase of management with the recognising and removing from play if we're there as a first responder. But it might also be that we're working in a sports setting as that person who is the main medical provider. It is often the case that a physiotherapist will be the most qualified health professional present at a sports event. And while that situation varies from country to country, often particularly touring with junior teams or development squads, there may not be a doctor present, but often teams will take a physiotherapist with them. So if we're present when there is a sports-related emergency, people will be looking to us as the person who's going to be providing that first response. So we do need some skills in that area. But when we talk about that, we have to remember that there's also some legal and scope of practice implications as well. And these do vary between countries. So we have to know what the law is in the country that we're operating. And also in the context of sport, there are sport-specific rules that relate to the management of concussion on the field of play, and we need to know the rules as well. So for those of you who work in sports-related coverage as a physiotherapist, these won't be new concepts to you, but with concussion it's becoming increasingly complicated because some of the sports are adopting specific rules for the management of concussion, and they do vary between sports. I'm not talking about that today, but that is something that if you're working in that area you would need to research so that you're adequately prepared. And we need the appropriate knowledge and skills. Now, we heard already that Italian Sports Physiotherapy Association has achieved accreditation with the International Federation of Sports Physical Therapy, and you now have the opportunity to work towards achieving IFSPT registration. And to do that, you have to satisfy the IFSPT competencies. And if you haven't seen the document, it's freely available on the IFSPT website, and it details the specific skills that physiotherapists need to have before they can be classified as a sports physiotherapist, and therefore largely equivalent to those who've done postgraduate training in other countries. And one of the IFSPT competencies is about acute intervention. And while many physiotherapists and sports physiotherapists are very skilled in the treatment of sports injuries that come into the clinic, it's a vital role of the sports physiotherapist to actually be involved in providing care immediately at the sport and at the venue. So sports physiotherapists need to be able to respond appropriately to acute injury or illness in both training and competition contexts. As I said, sometimes that might mean that you have to apply some response to a medical emergency, which may not necessarily relate to musculoskeletal injuries or things that we're comfortable with, but it might be asthma, it might be a cardiac arrest, or it might be a concussion, and it might be accompanied with other complicating injuries as well, and we'll look at that in a little bit of detail. And it's not just the IFSPT that say this. The International Olympic Committee actually also says that physiotherapists are an important part of the medical team, and in the absence of the doctor will be the most qualified person present. And in 2015 I was involved in the ISC Manual of Emergency Sports Medicine publication, and we were asked to write a chapter on the role of the physiotherapist on the field of play. And that particular chapter outlines the responsibility and also the skill set required for physiotherapists working in that area. If you are working in on-field situations, I really would recommend this book to you, not because I've got a chapter in it, but because the rest of it's really good. There's actually a good summary of the management of most of the sports-related emergency type things that you might encounter, from fractures to eye injuries to all sorts of things. Some we, as physiotherapists, know a bit about, some we probably know less about. So sports-related concussion, as Tony's already explained to us, is a traumatic brain injury, and we now understand that definition. It's also quite a common injury. And while the incidence rate varies between sports, we know that it actually accounts for a fairly high percentage of injuries in contact and collision sports, and that the incidence rates are increasing. And this, it might be more likely that it's more due to the increased awareness and the increased rate of reporting. The injury rates themselves probably aren't going up, though some people argue as players get bigger and faster that the forces generated in sports contact are higher, and therefore there is a higher likelihood of injury. But we also know that the rates that are reported are significantly under what probably are the real levels. And Felix, who I mentioned to you a little while ago, completed a study recently, which I was a part of, and we looked at adolescent rugby union players. And this was interesting because what we found was that the rates of concussion were 18.4%, nearly 20% of all the injuries sustained in a schoolboy rugby competition. So that's obviously a pretty high rate. And they were actually a bit higher than in adult players. But we also know that in this particular competition, where there was rarely a doctor present, that there was an even greater disincentive to actually report it or diagnose it as a concussion. Because under the rules, as Tony's already talked about, if you suspect a concussion, they have to be removed from the field of play and not allowed to return until a doctor clears them. So this is one of the challenges working in this area when you're a physiotherapist or first responder, is that sometimes coaches and other team people don't want you to say, I suspect a concussion, because that means that's the end of the game for that person. So these are, again, some of the ethical and legal challenges we're sometimes confronted with in that space. And a study done last year by a group under Professor Carolyn Finch, who you may have heard about, found that in Australian football community level sport, that the players by and large understood that the concussion guidelines are there to protect their health, and they were happy enough with that. But the nature of sports people is that they often are so committed to wanting to win, and they're so committed to not wanting to let their team down, that that was also a barrier to reporting concussion. So people were again tending to obscure the fact that they may have symptoms related that could be related to concussion. So these things just tell us. Whoop, yeah. So let me go back to my question before, and you're actually going to put yourself into the shoes of the physiotherapist who's on the sideline here. So you're working as part of a medical team. The doctor has actually had to go off to do some suturing for an eye injury on one of the players, and he's in the dressing room. So you're the person in charge, and you're looking after the team in the light colour there. And you see, this happen.
To get him fit and playing well, suddenly looks impressive. Lewis has not moved. Wonderful coverage from both
you're now
players.
on the sideline, and your player is down, and you can probably see a little bit of jerking and moving, but other than that, he hasn't moved very much at all. So let me see if I can get this right. This, in case you missed it the first time, it shows it again. And you can see he gets a very significant upper body impact, so around the chest, shoulder, head, possible jaw injuries, possible neck injuries. He falls like a rag doll, and it's a bit surprising he doesn't injure arms and legs in the process as well. So when you come out to the field of play, you're not too sure what you're likely to find, but it could be that he's got multi-trauma, as well as the fact that he's not very responsive. And under any of the signs and symptoms that Tony showed us before, you would be removing him from the field of play for a suspected concussion straight away. But even before we get to there, we may actually need to implement emergency procedures. So some of you have heard me speak before and talking about the role of the physiotherapist on the field of play, and we need to have really good crisis management skills, good knowledge of first aid, and also on cardiopulmonary resuscitation, because in that sort of situation it could well be that this person may need something like that. And if you go out there and the person is not responsive, not breathing normally, they're indications for commencing cardiopulmonary resuscitation, and that will be what we will do. And it might be that we suspect that there might be signs or symptoms associated with a possible spinal cord injury, and we might have to manage that. In fact, with concussion, it's often said if there's a concussion, assume a spinal injury is present, because the forces that are generated are likely to have caused a neck injury, and I'll show you some data on that shortly. But this is where the pocket concussion recognition tool comes in very importantly too, because once we clear people of life-threatening problems, we may have to make a decision as to whether or not they need to come from the field of play. And the pocket concussion recognition tool also is an instrument which comes from the 5th concussion consensus statement, and it's a useful tool for the assessment of concussion on the field of play. But as I've listed there, if you've had an impact like that, there may be injuries to other body structures as well. So without taking too much time about talking about this, if you're going to be working in the field of play situation, as I say, you need your first aid skills and your strong knowledge of cardiopulmonary resuscitation, and you also need to be good at doing an on-field assessment. So there's different tools or systems used for evaluating injured people on the field of play. More experienced practitioners, and especially doctors and paramedics, will often use the ABCDE approach, which takes you through a systematic approach for the assessment of injuries in the acute setting. And for those of us who may have not that level of training, we can still fall back onto the crisis management or cardiopulmonary resuscitation management guidelines, which gives us some good direction as to whether or not we need to start CPR, whether or not we need to call for an ambulance, etc. Now, the concussion consensus, the SCAT5 and the pocket concussion recognition tool both talk about the DRS ABCD approach, though I do know that in Europe that the European Resuscitation Council guidelines are a little bit different to that. Essentially they're the same, but you may be more familiar with this chart. In either case, if you're familiar with what to do in that acute phase, then you'll be well prepared. So the concussion recognition tool version 5, as I said, also comes from the 5th concussion consensus statement, and it gives people guidance on how to recognise signs and symptoms that may be associated with concussion. And just to take you through the parts of it quickly, I'll just show you some of the main boxes. So much like Tony showed us with the SCAT5, there's a section which talks about the red flags, and if any of these are present, then you should be calling an ambulance. So if someone's got neck pain or tenderness, double vision, deteriorating conscious state, if they're throwing up, they've lost consciousness, we're not sure if it's a serious brain injury or just a temporary loss of consciousness, and we aren't qualified necessarily to make that decision, so we call an ambulance. So the concussion recognition tool is described as being useful for those who aren't licensed health professionals or who haven't got an adequate level of training or knowledge or confidence to use the SCAT5 in its context. So I think for people who are starting to work in this area, it's a good one to become familiar with. You can take yourself through the concussion recognition tool quite quickly. I'm pretty sure Tony mentioned this as well, but all of these are available for free download through the British Journal of Sports Medicine, and you can familiarise yourself with them very easily. But remember that you need to be prepared to deliver first aid. So it goes on to say, if there aren't any red flag conditions, identification of possible concussion should proceed to the following steps. And the first part is, what observable signs did you see? Are they lying motionless? Are they slow to get up? Do they have a blank look on their face? Now, the video I showed you, you would be saying straight away, they're lying motionless. So for most sports, that is an indication straight away, without going any further, that person needs to be removed from the field of play and assessed by a medical practitioner. But it might be there were no observable signs, and it might be more about what the player is telling you, what symptoms they have. And the symptoms, there's things you'll be familiar with, such as headache, they may have nausea or vomiting, but sometimes players will just tell you they just don't feel right, they feel foggy, they don't feel quite there. So sometimes it's subtle, and we need to be familiar with those sorts of manifestations of concussion in case we're working in that field. And you can use memory assessment questions. The Maddox questions is a group of questions which were designed to test short-term memory function, and on the concussion recognition tool it has some of the questions you might ask people, what venue are we at today? A player should know that, and if they show any hesitancy around that, that's a sign that perhaps there's some memory impairment. But if any of these boxes show any negative response, then you remove them from the field of play and have them assessed medically. Just talk very quickly too about the need for ongoing monitoring. It says on the concussion recognition tool they shouldn't be left alone for the first 1 to 2 hours, but a lot of people say really you want to be monitoring them for at least 24 hours in case they do have a slow bleed in the brain, because the symptoms may be slow to manifest, and that means that you shouldn't let people go off by themselves. They should have a responsible person with them who's been warned of what to look for and can monitor their condition. But if you only remember the R's, and Tony talked about the 4 R's, the 5 R's, the 11 R's, recognise and remove, and that's a good start. So if you recognise the signs or symptoms of concussion, remove them from the field of play, you've executed your role as a first responder effectively. So that's on the field of play, and that's an important skill set for the sports physiotherapist. But what about the clinic? Do we have a role in clinical management of concussion? So here's another one of the IFSPT competencies, and this is rehabilitation, and that sports physiotherapists need to have adequate clinical reasoning and therapeutic skills to assess and diagnose sports-related injuries and to design and implement evidence-based interventions. So in physiotherapy we talk a lot, and proudly and rightly so, of using an evidence-based approach to intervention. As a scientifically based profession, I think we can be proud of what has happened internationally with physiotherapy, trying to use treatments which we know are more likely to work, rather than just treat people with everything. So we will use the evidence to guide our treatments. But let's put yourself now into the shoes of the clinic, and a patient comes in and says, I had a heavy impact at sport 2 days ago. The doctor said I had a concussion and that I now need to start a return to sport program. He said that according to the latest concussion guidelines, physiotherapy can help me get back to sport more quickly. Now, it might be that this doctor is familiar with the fifth consensus statement and the SCAT-5, and is referring to some of the things Tony talked about in terms of the appropriate graded return to sport protocol and appropriate rest. And here it is again, and Tony's spoken to you about that, so I'm not going to go through it too much. But the key principles are that we need to give the brain the opportunity to rest in the early stage, and it's a physical rest and cognitive rest. So we try to keep people off their mobile phones, keep them away from the screen time, those things as well, and just gradually increase the mental tasks as well as the physical tasks. And that if people aren't having any increase or return of symptoms, they can gradually move through the table, gradually increasing their activity. It's a good idea if this is guided and supervised by a health professional. So this might be something which you can do in the clinic, and monitoring people's symptoms as you give them slightly more challenging tasks to find out what level of physical activity they can comfortably manage, and that we will use that then as our exercise-based treatment until they're comfortable at that level, and we can consider progressing them probably a minimum of 24 hours later. So it's called the graduated return to sport strategy, but it's sometimes in the past been referred to as the stepwise supervised program for concussion, so you may hear that term as well. And as we've already talked about, essentially you can progress people when they no longer have any symptoms, and they should have about 24 hours or longer before each stage. But it's important to note, and Tony again talked about this, there may be considerable difference between the rate at which people can progress through from one stage to the next. People might move through some stages quite quickly and be at another stage for a longer period of time, and we just need to monitor that and respect where they're at before we progress. And there's an enormous amount of individual variation in this area. So, is rest after concussion the best medicine? There's been some evidence for a few years, and just very recently, I think literally in the last couple of days, in the latest edition of the British Journal of Sports Medicine, Catherine Schneider published a systematic review that looked at the use of rest for the management of concussion, and they concluded that a brief period of rest of about 24 to 48 hours is appropriate for most patients, and following this they should be encouraged to gradually increase activity. But the exact amount and duration of rest are not yet well defined and would require further investigation. So it doesn't greatly improve where we were at even before this systematic review, compared to what Tony was saying, we still have to use that individual grading, the use of individual outcome measures. But again, physiotherapists do that. We should be doing this for our clients anyway. So we're in a good position to help them. Going. So we know that rest is a good thing to do, but what else is there that we might be able to do? The very latest edition of British Journal of Sports Medicine, which is part 2 of the consensus statement edition, has a number of systematic reviews in it. One of which builds on some earlier work done, which shows that maybe physiotherapy and physiotherapists have a definite role in the management of concussion. And Catherine Schneider and co-authors in 2013 published a study that found that a multimodal treatment program which combines cervical and vestibular physiotherapy decreased the time to medical clearance for return to sport, both in youth and young adults. And it was a significant difference. 73% of people returned to sport at 8 weeks compared to only 7% who didn't have these treatments. And then just in this most recent edition of British Journal of Sports Medicine, a systematic review looked at what sort of treatments might be useful, and they concluded, looking at a range of treatments that have been postulated as being useful for the management of concussion, that the best evidence, and it's not the strongest evidence, but there is moderate evidence that targeted cervical and vestibular physiotherapy is more effective than just rest alone. So that means we may well have an important role here. And compared to some of the other types of treatments that have been suggested, such as cognitive behavioural therapy and some of the other mental health interventions, aerobic exercise, there's better evidence to support it. And there's actually no evidence, to minimal evidence, that medical treatments are of benefit. So the physiotherapist definitely has a role in the management of concussion, it would seem, based on this so far. We know from other studies that there are a number of musculoskeletal deficits that people have after a concussion injury. A lot of people will have neck pain, a lot will have cervicogenic headaches. They will have disruption in cervical proprioception, and they will have a loss of neck strength. Now, this isn't that surprising when you think about it, because Tony again told us the amount of force required to cause a concussion, and it might be as low as 50 G force in some people, but more typically it's up around that 140, 150 for most people to sustain a concussion. However, the force required to injure a person's neck is only around 4.5 G. So if you've had that sort of force transmitted to your upper body, the likelihood of sustaining a neck injury is obviously very high. And then very recently, Professor Hides, who's part of a group at Australian Catholic University that I was mentioning earlier, they did a prospective study with adolescent rugby players, and they found that people who had had a concussion had multifidus overactivation and poor coordination of their lumbopelvic movement. We also know that there's vestibular deficits post-concussion, and I'm going to move through these slides pretty fast because we're running out of time. We also know that there's balance deficits post-concussion. And the results for some of these surveys vary a bit, but we know there's changes in people's control. Some studies reduce that people have decreased postural sway. Some report that they have increased postural sway. The study that Julie Hides did found that people had decreased postural sway, but overactivity of the transversus and multifidus muscles, so that people are essentially splinting themselves because probably fear of movement and a loss of control through movement. So these give us things, again, we can work on in the clinical situation. So this is just a summary of some of the things that a physiotherapy assessment could encompass in a clinical situation after concussion. We could look at cervical spine range of motion and palpation. As I mentioned, there's been studies that have found a loss of joint proprioception and joint position error in people who've had concussion injuries. We could look at multifidus activation and try and train people to move more smoothly in balance-related tasks. Tony's talked about the tandem walk, and one study has found there if you do the tandem walk and add a cognitive challenge, it actually makes the test even more sensitive. So people can do the tandem walk but count backwards from 7 7654-321, 7654-321 on a repeated basis, and that extra mental challenge means they're more likely to show some postural sway or to be a little bit more challenged by that task, which means the test becomes more sensitive. Again, it gives us another tool we can use in the clinic. And time does not permit to talk about vestibular oculomotor screening, or VOMS, but that's a big topic in itself, and I'll show you a slide in a minute where you can get some more information about that. But joint position error test, these are some things again in the clinic we can do. In this one here, you have a simple laser pointer mounted to someone's head. They're situated 90 centimetres from the wall. They position the laser into the target. They close their eyes, you rotate their head 90 degrees and you ask them to relocate, and they should be close to where they started. If they have a distance of more than 4.5 centimetres, that's seen as being a significant joint position error, and that would give you an indication for doing proprioceptive retraining for the cervical spine. Talked about that one already, the balance screening with the tandem walk and the cognitive task. And you can also use tools such as the balance error scoring system as well, as both an assessment and also as part of a treatment. I saw a really nice setup here from one of your exhibitors with some great balance training modalities. They're probably a bit advanced for someone in the early stages of concussion, but like anything when we're talking about return to sport, we start simple and we gradually add more and more complexity and challenges to the task until they are at least as good as they were pre-injury, and hopefully even a bit better. Vestibular oculomotor screening, as I said, I haven't got time to talk about it now, but if you go to either of those two websites, you'll get a crash course in how to do all the tests in vestibular oculomotor screen, and that Neuro-Optometric Rehabilitation Association's got some good information resources. I'm very happy to pass the slides on to the organisers as well, so you can get these links. So essentially, like anything else, we assess and manage, and according to one physiotherapist who's been doing some work in this area for a while, she suggests that you'd manage the cervical spine problems first, then vestibular, and then ocular and behavioural symptoms. But that might not be, that's more of an opinion rather than evidence-informed, and particularly as Julie Hydes has again done another study, which is, I was talking about, has found that there's these change strategies in the lumbar spine as well. We should also potentially look at trunk muscle training, perhaps using real-time ultrasound as an adjunct to improving smooth controlled movement in balance tasks. I'll just move through these. So then the last one, just to talk really quickly, injury prevention. This is another one of the IFSBT competencies, and we want to make sure that we reduce the likelihood of people sustaining injuries or re-injury, and it's an important part of the role of the physiotherapist. So what can we do that might actually reduce the likelihood of injury or re-injury? Some of the data suggests that if people have had a concussion, they're significantly more likely to have another concussion, and they're also significantly more likely to sustain musculoskeletal injuries, even not necessarily associated with that original injury, but subsequent to the concussion injury. And this is probably due to unresolved balance or vestibular or oculomotor deficits. So our motor control training, balance tasks, muscular coordination strategies, these can be useful things to look at for injury prevention. Though at this stage, specific protocols, there's not a lot on it. I'm going to suggest that Mario's 11 Plus program would be a good place to start, and you do your neuromuscular training program with balance tasks and things like that before you get them to the return to play. That wouldn't be something we would do early though. Tony talked about some of the protective or prevention strategies that might be available. And here's another systematic review, again only published in the last couple of days. And it suggests while there may be some protective effects based on things like helmets and mouth guards, that really the future is the research into targeting the intrinsic risk factors, such as visual training. They specifically mention visual training, but also coordination training generally. And this again means that we probably could be spending some time looking at strength and control measures, and these are the last ones to leave you with. So one study from Collins and et al. Found that for every 1 pound increase in neck strength, the odds of a concussion occurring decreased by 5%. Only one study, but that would be a good indicator for doing some neck strengthenings. And also, Julie Hydes again did a study, in this case, on predictive values, and they also found that people had a poor ability to contract their L5-1 multifidus were more likely to have a concussion injury. So trunk muscle training may also have a role in concussion prevention. Early days yet, and we need to continue to watch the research. So thank you. There's just a bit of an overview of some of the things that physiotherapists may be able to help with in both the immediate management and rehabilitation of concussion. And once again, thanks to the organisers for the opportunity to be here, and thank you.